Good afternoon. Welcome to this webinar series that is organized by the ERN, EURO-NMD for rare neuromuscular diseases and the working group of on neuropathies. My name is Kleopas Kleopa. I would like to welcome you. Thank you for joining. We organize a series of webinars with the topic of inflammatory and dysimmune neuropathies. This is a very important group of diseases, and some of them rare, with a lot of new developments in diagnosis and treatment. And so we would like to highlight these developments and help the participating centers and everybody in better managing and treating these disorders. I would like to welcome our speakers for today and thank and introduce them. Jean-Philippe Plançon is actually a patient representative in the neuropathy working group. He has been living with a rare immune-mediated neuropathy for 25 years. He will give us the patient perspective on the disease. He graduated in the field of public health, education, rare diseases, advocacy, business, and corporate strategy. He founded the Association Française contre les Neuropathies Périphériques, a patient organization supporting people affected by rare neuromuscular diseases such as Guillain-Barré syndrome, multifocal motor neuropathy, CIDP, Lewis-Sumner syndrome, and Miller-Fisher, and other related disorders, including painful neuropathies. Since 2019, Jean-Philippe is the president of the European Patient Organization for Dysimmune and Inflammatory Neuropathies, EPODIN, and he's also the vice president of the French Rare Diseases Alliance, composed of 240 rare disease patient associations. After having been a member of several expert committees of the French National Agency for the Safety of Medicines and Health Products, since 2021, Jean-Philippe is vice chairman of the board of directors of this agency. Thank you again, Jean-Philippe. Our other speaker is Dr. Filip Eftimov, who is a neurologist at the Amsterdam University Medical Center with special interest for neuromuscular disorders and in particular inflammatory neuropathies. His research focuses on chronic inflammatory polyneuropathies and on disease overarching autoimmunity. He is the principal investigator of INC-BASE, an international registry in CIDP. He has contributed to several randomized controlled trials in CIDP, including PREDICT, PATH, FORCE-CDP, TRIP, and ADHERE, and has been the coordinator of 2 investigator-initiated multicenter randomized controlled trials, the IOC and OPTIC trials. He also serves as board member on the Inflammatory Neuropathy Consortium and the Dutch Neuromuscular Center. Thank you, Filip and Jean-Philippe, for joining and presenting today, and I will pass the podium to you to present your slides, and then we will leave about 15 minutes at the end for questions and discussion. Thank you.
Thank you for the nice introduction, possibly a bit long. We should have provided a bit shorter text, I think, Jean-Philippe, but it's an honor to give this presentation together with Jean-Philippe. We made this presentation and we had very nice discussions, and we'll have some of the discussions also here. So I will start with the first part. These are my disclosures, grants all paid to the institution. And this is what we are going to talk about. Obviously, we cannot cover everything, so we will provide a general overview, and which hopefully are kind of applicable to different diseases, and also kind of a disclaimer that will be on the focusing on a selection of the patient's perspective and not everything. So this is what we're going to talk about. First, we're going to talk about GBS, acute inflammatory neuropathy, when to consider whether there is a differential diagnosis. Another important topic, I think, is when to treat a very mild disease course of GBS. Then we go to CIDP, the diagnostic pitfalls, including the underdiagnosis and misdiagnosis. And then we'll talk about treatment, including the induction and maintenance treatment, and especially how long we need to treat. So I will start with a very typical case of GBS. Some of you are physicians, some of you are researchers, but this is just to kind of point out a very, very classical GBS case. So this is a 30-year-old healthy male, 3 days of ascending symptoms, first sensory starting in a fit and then climbing up. And then in 2 days, also progressive weakness in both arms and legs, and leading to inability to walk. Classically, people can have also signs of an infection 2 weeks before, often also diarrhea, often Campylobacter in that case. And in this case, it was further a healthy male with no medication, no intoxication, and perhaps important, but his professional life is a piano player. So at the neurological examination, you can find kind of the typical abnormalities that you would expect, with already some bilateral facial weakness, oculomotor involvement, inability of flexing his head from the bed, and rather profound muscle weakness of MRC, some grade of 3. And then in lesser extent, often you can also find the sensory abnormalities consisting of, for example, hyperesthesia of hypalgesia. And as you know, areflexia often develops within a few days after start of symptoms. So this is basically a classical case, both in terms of history and also the neurologic examination. So we probably say this must be GBS. There are actually close to no other alternatives, I would say. And in that case, you could probably, as also advised in the current guidelines, perform a lumbar puncture. And if there are no signs of polyradiculitis and infections, you could probably conclude this is an GBS, and you will treat accordingly with usually IVIG, and in some instances plasma exchange if IVIG is not available. So this would be more or less a standard case, as you can imagine. You might ask yourself also what to do with this kind of patient. We know that about 20% of GBS cases have severe disease course, meaning that they also get a respiratory failure, and they need to be also very well controlled, obviously. And you might say, is this 20%? Well, probably this is more, because we can also kind of have a better estimate whether there is a chance of respiratory insufficiency. And some of you might know this, but this is the Erasmus GBS respiratory insufficiency score that you can actually calculate based on only few parameters. And in this case, you would end up with a higher score than of 20%. And it has mainly also to do with the MRC sum score at the end, but also how long the symptoms have been progressing so far at the moment that you see them. So I think it's an important score that you can use in daily practice to also to have the discussions with your ICU, whether to admit them there or just to the regular ward. Similarly, and also this was even further being perfected, let's say, by the large IGOS registry. We can also have an estimate about people walking, both on 4 weeks and 6 months interval. And so here you can see also how that also change over time. There is a confidence interval around it, so it's not something that you could use it also to inform patients, but sometimes it can be also difficult, I believe, also how you bring this to patients, because it's certainly in the first phase, everything is new. Obviously, there is also a chance of going to the ICU. So, but certainly at a certain point also, this question might pop up for, am I going to be able to walk in so many months? But then not all patients, of course, are classic. So if we change a couple of things, which is sometimes we, of course, see, then it might become a bit more difficult. So we have kind of the same case, but I changed a couple of things in terms of the sensory symptoms a bit. That now last for 7 days, so it's a bit more, but they started actually in the hands, and there is close to no symptoms in in the legs, sensory symptoms, but there is some minimal weakness, which is mainly in the legs and in the hands, but he can still walk 1 kilometer. So it's in that perspective, certainly there is disability, but not so much that he cannot walk. There's also pain now in the neck and irradiates to the hand. It altogether leads to the fact that he's not able to play the piano. And there are some minor problems with the bladder control. Again, no medication, no intoxication, and he's still a piano player. So then you continue with the examination, and now you don't see any abnormalities on the facial musculature and a normal eye movements. You see some limited weakness of the hands and only of the anterior tibial muscles, and you find also sensory abnormalities. And again, you find areflexia, and of course, because of the pain in the neck, perhaps you would think maybe it's a spinal cord also problem, but you're reassured that there are flexoplantar responses. Yet again, you will probably be thinking, well, this is what I learned at school. We have GBS with the classical variants, and if the neuromuscular neurology will probably know there are also some very rare variants. But this patient somehow does not fit any of them, at least not at this point at 7 days. So then the question is again, so what are you going to do? So I think one of the messages that I would like to point out that the more we have that obviously with all clinical pictures that we have, but the more the less classical the picture is, probably the more research of diagnostics we need to do. And I would probably also, in this case, do also a contrast enhanced MRI of the spine, maybe do a bit more elaborate lab. And for sure, I would also do the lumbar puncture. And then I think a very important question arises that sometimes I also have with residents here. As you might know, it's a bit less than the classic phenotype, as I said, but the patient is still able to walk. So he was able to walk a whole kilometer, and it's already 7 days. So these are more or less also the criteria that was specified in the guidelines that you normally, and also all the trials that we did were based on the fact that you treat the inclusion of patients when they were not able to walk for 10 meters. So now he's able to walk and it's 7 days. So are you going to treat, yes or no? So this, I think, one of the first moments that I would like to invite Jean-Philippe. So what would you, from patient's perspective, how would you think about this?
No, of course, we know that criteria for you as clinician are crucial, but if you consider the patient perspective, of course, as you highlighted, there's a lot of uncertainty on the condition and the possible deterioration of patient. But if possible, the doctor must always be in favor of the patient. If you hesitate to treat it, and if you have the possibility to have a treatment access, of course, and the ecosystem is in favor of the possibility to treat the patient, you should try to treat your patient, because once again, we know it depends of your condition, your local conditions, but anyway, at the end, the depth must always be in favor of the patient. And then if you consider that, and if your patient is able to have exchanges with you, there is the question of the management of shared decision making, which is a huge question, and there is a lot of publication around these words. But it's very important if your patient is able to communicate with you. And on the next slide, you've got just a few words of what is the decision making. ENMC made a very interesting work in 2019 on the question, and this is a collaborative approach between the clinician and the patient to share the best available evidence when faced with the task of making decisions. And in the case of emergency, of course, it can be different if your patient is unable to talk, or if it's a question of death or not of your patient. But when it's possible, the shared decision making is the best way. What as clinician you have to express? We have this discussion, Filip. As clinician, you have got your own advice on the question, and your patient and you should have a dialogue, in fact. And here are the best conditions, but we are in neither word, of course, but collaboration, evidence-based, open discussion, patient support, and informed preferences. But if you consider GBS, of course, it's a little bit different than if we consider the chronic forms of disorders that we will talk later.
Yeah. So normally, and in this point, of course, we advise patients, and after this advice is also followed. So in this case, I would probably also treat, because I think it is very disabling for this specific patient, especially given his professional career as a piano player and not being able to do that. The question might be different, though, if it was like 3 weeks down the road, and because then we know that IVIG probably has close to no effect on this, because the damage is already done. So then it can change, of course, but in this case, I would probably do that. So, and I think it's also important, we also discussed this a lot, Jean-Philippe, I think IVIG is not the only treatment that we give to GBS, and the recovery is certainly promoted by the rehabilitation process. And that can be difficult. We know that some patients with GBS can have a lot of pain in the beginning, and then it's also difficult to start up the rehabilitation. And normally you would first want to treat the pain as well as you can. But then at a certain point, one would like to start. So, and you said that there were kind of mixed. Well, it's very different in different countries. How this could go? Could you elaborate on that?
Yes, for sure. This is a question that we often have from patients, especially in Guillain-Barré syndrome. Say, how long will be the process of the recovering? How long? What will be my after effects? So, of course, I'm sure as a clinician, it's complicated for you to answer that. But if you only consider the question of rehabilitation centers, this is also sometimes very challenging. And as you said, it depends on many countries. For example, in France, all depends where you live. On the national territory, it can be very difficult to find a rehabilitation centers. Sometimes it's not complicated. Then, once again, all depend on the countries, but it is also a question for patients to find the centers with the expertise, necessary expertise to be well rehabilitated, in fact. And at the end, probably there's also an interesting question, but which is the question of the self-rehabilitation. Well, when it's possible, when it's a good moment, of course. What can I do by myself is also a question from patients.
Yeah, and in addition to after the rehabilitation center, obviously the rehab doesn't end. So people often continue with their physiotherapy, and then we get the same questions, obviously, after a year or second year, and especially as fatigue is then usually one of the biggest problems, and sometimes the pain. All right, so then we'll continue also to the second part of the talk, so CIDP. So this is something that we drafted a couple of years ago, just before the new guidelines were published. And in this, we kind of actually try to emphasize in this paper that we are actually doing something very strange in an autoimmune disease. Because if you have, for example, an encephalitis, everyone would be looking for immunological support of your encephalitis and would look for the antibodies. And that is actually the case with the most autoimmune disease what we have. And yet in CIDP, but also in MMN mainly, we base our diagnosis basically on the clinical phenotype, and we add a nerve conduction study, and sometimes we add some other tests, but close to no immunological tests because we don't have any. So that makes it a bit of a problem. And I think we really need to focus also on finding the causes, the pathomechanistic pathways of the disease, and then develop also these immunological markers that can help us with the diagnosis. Also in CIDP, we have different subtypes. So the typical CIDP is more or less about 70%, consisting of proximal and distal weakness with sensory abnormalities. I would really like to emphasize the proximal weakness. So I think if you talk to CIDP experts, if they see like this MRC, all the muscles are grade 4, both proximal and distal, then the diagnosis CIDP is probably very likely. And of course, you need to exclude some others, but it really helps. But the moment that it's only distal, or if it's multifocal, then, and that's also what we know from literature, the proportion of misdiagnosis goes up immediately. And then we also have, so the LSS is the Lewis-Sumner syndrome, now called more the multifocal CIDP. We also have the pure motor and the pure sensory forms. The test, the EFNS, the first EFNS criteria were also compared to other criteria, as there were many in the last decades, and they were performing rather well in terms of sensitivity, specificity, yet there was also a need to improve those. And we try to do that with the recent EAN guidelines. We kind of try to simplify it. I'm not sure whether we completely succeeded, but we did at least make 2 categories, CIDP and a possible CIDP, rather than the previously 3 categories. We try to define the clinical pictures a bit better. And as I said, we try to simplify it, but we still have the problem of the many variants that we have. And in terms of the variants, also how much diagnostic research you should do. Because also here, a bit maybe less than the GBS, if you have a very clear-cut clinical diagnosis, especially with the typical, and you have your EMG, then your nerve conduction study that is really typical for demyelination, and you have ruled out other cases, then you're probably finished. But sometimes you will need to do more. And the other things that we can do is, of course, the lumbar puncture. We can look structurally at nerves, preferably with ultrasound rather than MRI, and maybe also, and actually only in rare cases, we perform nerve biopsy. The problem starts when the clinical diagnosis is not typical. Then you really have to avoid putting too emphasis on any of the diagnostic tests that you could do for CIDP, because they are basically not specific. And we kind of made a summary of when things can go wrong. So we made some distinction in terms of misdiagnosis and underdiagnosis. One thing that we should realize is that nerve conduction studies can show signs of demyelination, but you can find these signs with many other neuropathies. And it can be very difficult, if not impossible, to distinguish between, for example, an anti-MAC neuropathy or some of the hereditary neuropathies. Finding a demyelinating neuropathy doesn't mean it's CIDP, would be also one of the other diagnoses, such as POEMs. At the other hand, we have a lot of referrals where sometimes it's considered a CIDP, but based on, let's say, kind of a liberal interpretation of the nerve conduction studies. And I think in most cases, this is a very low CMAP amplitude that is with also corresponding slow velocity that was interpreted as a demyelinating speed. So we did make recommendation also the new EN guideline note when you can consider something being really slow. And then we have the underdiagnosis, especially I think in the patients with the less typical syndromes, I would say. And that can be, for example, because we do not do sufficient neurophysiology. If you test only 2 or 3 nerves, of course, there is a big chance that you won't be finding the demyelinating changes. And you have to realize that, especially if clinically it could be more polyradicalopathy, you will be probably also missing it with your nerve conduction tests that are obviously focusing on the distal segments. So, and also when we talk about the last modalities that we used, we know that the lumbar puncture can show increased protein in CIDP, but you can have increased proteins in a patient who has diabetes. The protein goes up also with age. So having a 0.8 or 0.9 can help sometimes, but you also have to be very careful that that's not the only argument for your diagnosis of CIDP. And actually the same applies also to the nerves or the ultrasound. I think it can be it's relatively sensitive for the CIDP diagnosis, but also here not very specific. So in practice, you would probably have two scenarios. First, the perfect clinical picture and a very clear nerve conduction study. You rule out with your lab results many other causes, and then you have CIDP and you treat accordingly. Or you have this less perfect clinical picture, and I would urge you to do not only a nerve conduction study, but probably additional tests to be sure as possible. And if you decide to treat, be very critical about what this treatment response is. So they didn't get worse after treatment is not a treatment response. They should get better, and you should also have objective measurements to use that.
We understand, Philippe, that you are talking about very complex disease and with a huge heterogeneity. And for us as patients, I just would like to come back on the question of the diagnosis announcement, which is for us essential and sometimes a turning point in our patient's life, of course. So maybe because we have a lot of clinicians in a room in the audience today, it's important to say once again that it requires to be cautious for patients. I mean, you need enough time to explain, to talk about the diagnosis with your patient. Sometimes it's interesting to have a teamwork, not to be alone as a clinician, but also to work with a psychologist or a large team. And of course, because for a patient, it's a difficult moment, you have to ensure that the patient and the family or the family is able to understand. And it can completely change the way that the patient will have a care pathway after this moment, because for patients, if it's not clear, they can have a sort of medical wandering. I mean, they can continue to consult other physicians and because they don't understand what happened. Sometimes it can happen for them, especially if they met an expert like you are. It's important to take care and to be cautious with this very crucial moment for the patient.
Yeah, it's an important point. And I mean, of course, I said the diagnosis is relatively frequent, but it really takes time, as you say, to discuss everything. And often you can only discuss maybe the diagnosis, but there will be a lot of questions. So often you need a second appointment. Or when you have decided how to treat, then there will be like a million other questions on how long and how fast will the improvement be, etc. And even if you explain it the first time, then not rarely it's completely forgotten by the next time that you have seen them. So you have to come back, and you can also share some information also, obviously, for patients. And that is also on the GBS CIDP Foundation, for example. In the Netherlands, we also have an expertise site, which is in Dutch, that you can also refer to. So then it's a very interesting topic that was kind of started more than 10 years ago. First, also after our trial, the PREDICT trial, we showed that some patients were misdiagnosed with CIDP, but I think the first paper that really kind of focused on this misdiagnosis was Jeff Allen's paper with Richard Lewis. That a kind of a staggering, almost half of patients in US that were referred to his clinic was actually did not have CIDP. Also in the Netherlands, the Rotterdam group looked at the referrals that they got. Half of them were treated, so CIDP. So that would be probably of those 32% the real CIDP misdiagnosis, what can say, or it was just tried as kind of a diagnostic modality, the treatment, to see whether they improve. But certainly that can be difficult. It does state it. On the other hand, we just performed the OPTIC trial in which we included 77 treatment-naive patients. And we had a very low score of misdiagnosis, so only 5% had an alternative diagnosis that 5 years ago were also even considered to be CIDP, so the paranephropathy, so 3 of the 4. So I'm not sure that it's always a big problem, but we do know that the referral centers are probably doing a bit better. But I must admit that I have also changed the diagnosis during the line. Usually that is in the first year. So I think that's important, and especially if they do not improve the treatment, and this has been added also to the guideline. So if you treat patients for CIDP, they don't improve, first that you need to do is reconsider before you start your second treatment, I would say. There's also underdiagnosis for sure, but it's very difficult also to find these figures. And what we don't know, we don't know. But there's certainly also a problem of underdiagnosis. I don't know, from your perspective, what do you think, what it, and not only
Yes.
CIDP, but also MMN, what do you think? What's a bigger problem?
No, both are a problem, of course, for patient, misdiagnosis and underdiagnosis. But if you consider, for example, MMN versus ALS, of course, misdiagnosis can have a devastating psychological effects. In one hand, you are explaining to a patient that he probably will die. And in the other hand, if he has got an MMN, you can treat him or her. So it's completely different. And when I say that, I don't mean it's easy to have the diagnosis, but it's important to consider what happened at this moment. This is not the same thing, ALS versus MMN. And if you consider the underdiagnosis, well, we know that if we consider rare disease in a broader way, it's a huge problem, of course. Even if it's better now, you for CIDP, for example, you need on average over a year to have a diagnosis. And sometimes I remember we had a survey a few years ago in France. We can see people with 16 years on average to have a diagnosis. Once again, because it's complicated to diagnose, and sometimes the journey of the patient can be very complex. But it's a huge problem, and for that, the community tried to tackle this. But we know it's complicated. For example, I took 2 or 3 examples. The first one is an application, the RDK application. It has been developed with Orphanet, for example. And of course, the European Reference Network is mobilized on this question. And last year, you can find some videos on the website of EURO-NMD. But we work on the good practices, on the knowledge, to advices for general practitioner. And when I say we as patients, we were supportive of this project. And we worked with your colleagues in different countries to give some green or red flags for non-experts, because we know that the general practitioner is the first line medical doctors, and it's very important in the journey of the patient. And just to finish, we've got a very interesting project within EURO-NMD, and with the patient advisory board, we are working on that. It's a patient journey. And last year, you can find it on the website, we work on MMN, just to better understand and to raise awareness on the journey of the patient living with an MMN. So both are important, of course.
Yeah, that's important, and especially I think with when there is a very kind of a slow disease course, then the misdiagnosis is also more, or underdiagnosis is more apparent. If someone has a very rapid deterioration within a month and is not able to walk, probably diagnosis will come soon. But especially MMN and multifocal forms in CIDP sometimes can be very slow, and then these problems can occur. And also, and they can also resemble obviously very prevalent other neuropathies like a pressure palsy, etc. All right.
And sorry, just Filip, just to say that you're right. Patient organization locally, nationally, and at the European level sometimes can be very important for patients, because they can talk and share experiences from expert patient.
Yeah. So I also just one slide to touch on MMN, on IgM-related neuropathy. New guidelines are expected for both conditions in 2 or 3 years. In MMN, for sure, the ultrasound will have also a prominent role in the diagnosis, because we know also that we have this, what we call conduction block negative multifocal motor neuropathy, that sometimes can be identified by the ultrasound. What I always find kind of difficult is the anti-MAC negative, but what you do feel is an IgM-related neuropathy, and where the exact boundaries should be around this neuropathy, because sometimes we do see patients that fit perfectly the clinical picture of CIDP with proximal and distal weakness, very relatively fast progression. and you find an IgM when you do your lab monoclonal IgM, but you don't feel that that is really being the cause. While often we get these referrals, and probably many of you also do, with what you feel is more like an idiopathic axonal neuropathy, but because once the guideline dictates to do also a paraprotein check, you will find an IgM with increasing age. Obviously, you will find IgM AMGUS more often. So this is, I think, and where the boundary is whether it's axonal or demyelinating, how fast the progression is, whether there is more agnostic abnormalities, position sense abnormalities that you would expect for a simple axonal neuropathy. That is all a very subtle arguments to reason in a specific direction. So we go on to the last part, the treatment of neuropathies. So in general, I'm trying to separate the treatment into induction treatment and maintenance treatment. Actually, I kind of, we do this, for example, with vasculitis and many other autoimmune diseases. And I think it is important also to do it with chronic neuropathies, because different stages of the disease also require different objectives and different treatments and different reasoning in a way. So in CIDP, you could say that the induction, that the objective of induction, at least, it's first to have maximal improvement, also from patient's perspective. But I would really like to argue that the remission, trying to reach a remission from the beginning with the induction treatment, should be an equally important objective. You know that we can use IVIG, steroids, and plasma exchange. We'll come back a bit later to this. And then the question is whether from induction you will need to go to the maintenance. So also when talking to patients, I think it's very important to say, yes, we'll start treating. Usually we will get you better, and hopefully we will also get you into remission. It doesn't mean that the C part of CIDP, chronic, is actually a misnomer, because of course it was meant to kind of make the distinction with the GBS, with the acute neuropathy, but it's not always chronic. Yes, it can be months, sometimes years, but it's not chronic, because often with chronic we mean it forever and ever, and this is not always the case. But the objective during maintenance treatment is different. You want to keep them stable. Usually will be, certainly in the high income countries, we will be using IVIG for this, but you could do it also with steroids or use other immunosuppressive, for which basically there is no very good evidence, but we use that nonetheless. For the multifocal motor neuropathy is a bit simpler, you would say, because remission is not that often seen, and most patients will need maintenance treatment. So the induction objectives would be indeed first to get a maximal improvement, and then search for a lower dose of IVIG that kind of makes them maintain stable. And then we have the anti-MAG neuropathy, where actually everything is based on getting the remission, as long as that we succeed to. Sometimes you get some improvement, but actually we normally say the reason why I'm treating you is to prevent you getting worse. We can use the rituximab, the dexamethasone rituximab cyclophosphamide combination, and second line often bendamustine. And increasingly we are thinking about using the Bruton tyrosine kinase inhibitors, that you might say it is more a maintenance treatment than an induction treatment, but there's and some trials are now being performed. So this was one of, I think, the topic throughout my research. So how do you choose the induction treatment in CIDP when you know that IVIG probably has less adverse events and a faster improvement, maybe even more often improvement? We don't know that for sure, but the steroids are cheap. We know that they can give more adverse events, but they seem also to give longer remission. So basically you need to choose between both objectives, and that makes it a bit difficult. This is also what we did also the IVIG with steroids OPTIC trial. The results were presented. I'm not going to talk about this now, and hopefully will be also published soon. But you would also like to go to treatments that provide both, and whether this is with steroids or maybe with rituximab or other treatment, I think we really need to focus on this treat early and treat hard, rather than getting all these patients into this chronic phase with maintenance treatment. So I was wondering, how do you think about this, Jean-Philippe?
No, this is probably a question of good timing. It was interesting because you asked some question and we had the opportunity to have many exchanges around that. And probably this is the question of good timing. And for sure, preferably at a distance from the diagnosis, and to be sure that the patient can understand the flood of information that we talked previously while during the diagnosis announcement. Well, this is also, once again, sometimes a question of relationship, direct relationship between the clinician and the patient. And the quality of this relationship needs time. You need enough time to spend with your patient to explain the objective, to be sure that he can understand the objective, and to be sure that the patient will understand what remission means, what maximum improvement means in his or her condition, and what does it mean to have a patient stable? What is stable for you as a clinician? What is stable for me as a patient? And I think it's very interesting and important to confront and to have the discussion between you two.
But indeed, this is what we had in the next slide. So what is actually keeping them stable? Because I think many people have also different ideas on what stable is. So some would say maybe if you have like IVIG every 3 weeks, that you don't have fluctuations, that you don't have this what we call wear off. But people will have also sometimes bad and good weeks. So it is also, there is a kind of a semantic discussion on what fluctuations are. And then, of course, we have also some people say, okay, we just continue treatment to reduce the chance that they will have a relapse. But there are certainly also reasons to do, you could also argue that you are giving the treatment because you don't want to accumulate this external damage that leads to the disability at the end, or maybe you can say we are doing it for all the above. So this was, I think, a nice figure that you also introduced before. So the
yes,
mismatch between what we think we are doing and what the patients think that they are doing.
Yes, I thought it was interesting to share it with you because it's interesting to see that the perception from the clinician, from the patient can be different. And I don't want to say this one is better than the other one, but they are different. This is the reality. And you, as the physicians, should have that in mind. It can be a guidance for you to better understand that what your feeling is can be different from the patient perspective. So there is huge disparities, and it's a recent discussion that we had with Adelphi. These are data from Adelphi.
Yeah. So maybe, well, we'll kind of also maybe discuss this, it was because we have a couple
yes, of course.
So I think I would like to touch on in the last minutes to this final point of overtreatment, because we know from the ICE trial that there is for sure efficacy of IVIG when giving it after 6 months, because there was a difference of 40% here in patients who got a relapse. But it was also important to see that 50% of patients did not have a relapse after stopping IVIG, and that was also the reason why we also focused on this potential overtreatment in patients, because there were many questions that we need to answer. How often is this? How can we identify those patients that might be eligible for a withdrawal? Whether you can stop immediately or do you need to taper? And if you do a withdrawal and they appear to be IVIG dependent, how fast do they restabilize? So we did this trial, you might have read, it was published in Brain. We randomized 60 people who were completely stable on IVIG for at least half a year. And we put them on placebo or to IVIG, of course, double-blinded, everything as it should. And then we saw that 60% had a relapse, meaning also that 40% did not have a relapse. And that was more or less what we expected, that may be also similar to the ICE trial. But what we were really flabbergasted was about this. 40% of the patients who were on IVIG had a relapse during those 6 months of treatment, while nothing was basically changed. So they still got their IVIG in the same dose that they had before. And nonetheless, 40% dropped out of the study because they felt they were deteriorating. So we asked ourselves, obviously, why did this happen? So I think there were many reasons. I think fluctuations are part of CIDP. So even a minor fluctuation, the moment that you start IVIG treatment, can be seen as a well, caused by stopping IVIG. There is certainly a nocebo effect. So this is the negative effect of an intervention, the opposite of a placebo effect, you would say. And then, of course, it also illustrates that probably the clinical scales that we are using are not always valid to measure a deterioration or improvement. We show, I'm not going to go into detail due to time, but we can show basically what you would like to have is the light. We compared several outcome measures and the minimal important differences on these measures that we currently are using in all these trials. And you would like to have this graph, the first graph, the light blue and the other blue completely separated, which is certainly not the case. And when we are looking at the visits when patients were deteriorating or were not deteriorating. So the changes were basically all over the place. And we also kind of concluded that it is very difficult, certainly if you base your conclusion on a single outcome measure, to say that someone is really deteriorating or really improving. So I think I see Cleopas also coming into play. So we need biomarkers. We'll come to a closure to assess disease activity. We also looked at the restabilization, and we did see that most, not all, but most people, 90%, did restabilize soon, usually after 1 or 2 infusions. So this is also important when you discuss with patients, that you can tell them that that almost every time we will be restabilizing as fast as possible. So we drew a couple of conclusions that we need withdrawals, the only way to assess whether we need IVIG, and that it is almost always safe. So I think
maybe just one word to say that it's crucial. The key idea here is to say that it's very important for you to reassure your patient and to be sure for the patient that they can maintain contact and how they can maintain contact if the situation worsens for him or her. Because if you want to have a withdrawal with your patient, yeah, we need to you have to organize the way it works if the patient worsens.
Yeah. So I think this was this we're not going to talk about because they are not challenges, but just future hopes that we will get new treatments. But even then, we should realize that they are not compared to IVIG, at least not in the current trial designs. And this is certainly something that we'll need to find what the actual place of efgartigimod and the complements would be when they're once on their market. And hopefully with this kind of studies, like INK-based, the IGOS, and the IMAGINE, we will be able to provide much more knowledge, including the biomarkers, to answer a lot of these questions. So with that, thank you for your attention. And Cleopas, I'm sorry that we are 3 minutes over time.
This is fine. Thank you very much, Jean-Philippe and Filip. It was a very interesting and nicely discussed topic, giving us both the clinicians and the patient's perspective on all stages of diagnosis and treatment. Thank you again. We have some questions. I will go over them first. So Mahmoud Al-Haji is asking, he's asking about the treat or not treat in the GBS scenario. So I think this is an important issue. The concern is if you don't treat and then the patient deteriorates suddenly, will you have lost time by giving IVIG at a later time point? I think that's basically the question here. And I think this is an important issue to know when to treat and really, and hearing also Jean-Philippe's perspective, patients will really prefer to be treated rather than running the risk of having more ability. Yes.
Of course, if there is a doubt, once again, the benefits must go to the patient. But we know it can be complicated for many reasons because there is sometimes shortages or complication to have an access to IJ, for example. But if this is not the problem. Yes, of course. I think, well, if you keep beside the side effects, if as a clinician you think as your patient can't receive IG for medical reason, of course. But if there is no medical reason and if you have an access to IG, yeah, you should treat your patient, of course.
Yeah, so yes, I mean, if you treat, you would like to treat as fast as possible. That's for sure. But I've seen both cases that I started treating and patients actually 2 hours after the IVIG said, well, actually, I'm feeling better. And then we were waiting for 5 days to discharge him. And well, it was actually good enough to, and that was not IVIG effect. Then I could have spared the IVIG. On the other hand, once I didn't give IVIG to one who had bifacial diplegia and had only sensory symptoms. We know this phenotype, and I was very disappointed by the improvement 2 or 3 months later on the facial expression. It was still almost paralytic. So, and I was like, okay, maybe I should have done it. Maybe it would have helped. But what we do know, it doesn't really help a lot on 1 year when you in terms of fatigue, and there are no signs, as far as we know from research, that it has really improving the long-term outcome. So it's important also, I mean, yes, we also want to do things and help people, even doctors. You said there's one sentence in War and Peace that he said that the patient became better despite of the help of the doctors from Tolstoy. And yes, we also want to help people, but we need to do it with good arguments.
Maybe we need even more good predictors.
Yes.
But it's always a possibility, yeah. So another question that came from Olivier Scheidegger is that what was the highest CSF cell count you ever accounted in GBS and in CIDP without other concurrent disease?
Yeah.
Filip.
Yeah, that's a good question, Olivier. Well, GBS, we say, well, 50 to 100 you could see, but and it doesn't preclude the diagnosis, I would say. I would probably treat it, but of course you will think once again about where it's not a Borrelia and look at the serology, or if it's a typical, maybe treat, or sometimes even we have had that we treated both antibiotics and IVIG. In CIDP, we actually also performed a study. There was 5% together with our Serbian colleagues. 5% had more than 10 cells, and that led to all kinds of diagnostic, obviously, sometimes multiple lumbar puncture to rule out leptomeningeal metastasis. And what we actually always saw is that they dropped down to normal, to no cell count, basically in 4 weeks. So then I would repeat it probably, but it was a bit lower than in the GBS, so about 50-ish at most. Yeah.
Okay, great. There is another question from Zeynep Elmas. What do you think about serum neurofilament light and peripherin? I guess it's peripherin as a biomarker.
Well, it really depends on the disease, I think. So in GBS, we know it can be sky high, and the problem with neurofilament is it takes a long time to go down. So we know that. So it doesn't really, it certainly helps you in terms of predicting the outcome, but you can already predict the outcome based on the clinical score. So I'm not sure whether it adds much to the clinical score. At the same time, then we have this, in CIDP, we also did research that it was increased in 1/3 of the patients with active disease. So the neurofilaments are usually not that high in CIDP, and sometimes, and they can go down a bit on a group level. Probably you can find difference, but individually it's very difficult to use them in practice, and especially as as I said before, it takes a long time for them. The dynamics is very slow. So usually you will already see it on the clinical outcomes. And this is exactly the whole idea about biomarkers. It is to be more responsive than the clinical outcomes, to be using it. Well, the peripherin idea is indeed that it's more responsive, faster. And we did it mainly in GBS, or Michael Land did it. And we hope to, in CIDP, it was a bit less clear in the first pilot data that we had. We might be using it, and periaxin is now the third, but there are many more, and I think we should kind of have a pipeline of testing them all. I do use neurofilament more often in vasculitis neuropathy, because that then is often really, really high. And then you start treatment, and then you wait for months anyways until they really improve. So then it can help, especially when you consider a relapse and you're not sure.
Yeah, I mean, definitely useful for decision to treat, and also for monitoring and prognosis.
Yeah, it can help sometimes, but not. If it's low, it's low. So if it's like 15, it doesn't really help a lot, or 20 or 25. So it's difficult to. I'm not using it yet that often, not in the inflammatory neuropathies, to be honest.
Okay, great. I don't see any more questions from the audience. I had a question. So for CIDP, misdiagnosis and underdiagnosis, that seems to be, a crucial point in the CIDP challenge. So it seems that we're more likely to misdiagnose than underdiagnose. Would that mean that we have to make the diagnostic criteria more strict?
Yeah. Well, I'm not sure what this is more. I mean, we now know better what we are misdiagnosing. I'm not sure, but we don't know what we are underdiagnosing. So I'm not complete. I couldn't really say for sure that it's a lesser problem. So if you look at the criteria now, the new criteria, the CIDP, what we call CIDP, those are actually more specific a bit than the former criteria of when you would combine the definite plus the probable, while and they are less sensitive. So you would actually say they are slightly more specific. But I would just say, if you're in doubt, just please refer them to a referral center of CIDP and have the diagnosis confirmed, because this is really major. I mean, to see someone being treated for 2 years with IVIG, 200,000 euros, and you think, but this is not CIDP. And especially if you consider that sometimes the diagnosis is POEM syndrome, which, I mean, they might die if you have the wrong diagnosis. So it can have very huge implications.
Yeah. Great. I think we're coming to the end. I don't see any more questions. I would like to, unless you have any more comments, Jean-Philippe?
Not really. It was a pleasure to have this talk with you, Filip, and to spend time to prepare this webinar. And thank you, Cleopas, for your contribution. It's very important for us as a patient to be present and involved in this webinar, because I'm sure behind the screen there is some patient today. So thank you for that.
Thank you both again. So this was the first webinar in the series. We have next week Peter Van Doorn. He will talk about GBS, update on GBS guidelines. So please join us next week. And thank you again all for participation. And many thanks to Jean-Philippe and Filip for presenting today. Thank you.
More than welcome. Thank you for listening.
Bye-bye.
Bye-bye.
Bye-bye.